And my name is Dr. Abad Khan, and I'm an interventional cardiologist currently practicing at St. Joseph Hospital, Ghaziabad. We are on day 2 at the CRISP TV 2025, CRISP 2025, and an amazing sessions are going on continuously in the two halls that we have. Today we have our next guest is Dr. Balbir Singh, a name actually who needs no introduction among the cardiology community. The track record and the recognition for him has been unparalleled. Dr. Balbir Singh is a Padma Bhushan and he's a group chairman, cardiac sciences, Pan Max Hospitals, and chief of interventional cardiology, electrophysiology at Max Hospital, Saket. So, welcome to the CRISP TV, sir.
Yeah, very well, warm welcome, and very nice to be seeing you here in the TV.
So, just prior to you, I was having a talk, and Dr. Kirti Punami was giving his talk. He has been a big believer of laser, and I know only a few people in the country have, and you are one of them who have an expertise and is a big believer of laser and orbital atherectomy and laser and other devices. So, do you believe that the orbital atherectomy have the qualities of being the single mainstay of extensive debulking, calcium debulking device, or even after the latest published data for the orbital atherectomy was not going in favor, the Eclipse trial?
Right, so first thing is laser, it's a good technique, but has several limitations. I would think complications for treating only calcific lesion is little higher than orbital. B, it is good for in-stent restenosis where the stent has not expanded. But beyond that, orbital has great advantage. It can take care of superficial, deep, and calcific nodules. So there are three kinds of calcium which hurt us in the coronaries: superficial, deep, and nodules. So now orbital can be a solution to all three, which is amazing thing to have. And with that, if we talk of orbital as an agent which can take care of what an IVL does. It can take care of what laser does. It can take care of what a rota does in a much better fashion. So it gives us an opportunity to treat. Now, coming to the Eclipse trial, these trials to randomize patients is very difficult. So they were not randomized in a fashion that I would do in my clinical practice. So in a clinical practice, not everyone will have orbital. There will be patients who will not have simple techniques done rather than an orbital. So if you compare a simple technique against orbital in not so deserving patients, you may not come at great conclusions. But even Eclipse cannot be called as a negative trial because the stent expansion was better in the orbital arm. So to do a randomized trial with not all having imaging, some having imaging, some not having imaging, how did you decide on the severity of calcium? Angiographically to define calcium can be sometimes very fallacious. So all these factors come into play when you design this kind of a trial. The fact remains is that if you are able to expand your stent well, you will have good long-term outcomes. And that is the single major driving factor. And in my experience, if you do an orbital and then do followed by the DC, then by a simple balloon, NC balloon, you will get much better expansion than you get with just NC balloon or just a cutting balloon. So it adds to the benefits. So there's no question that it is safe and very effective.
Sir believes, and he's putting it rightly also. Not all patients need a balloon angioplasty only, and not all patients will require rota ablation. Then why all patients should be subjected to orbital atherectomy? Orbital atherectomy has its role, and I think Sir is saying right. It is here to stay because the mode of action and the effectiveness has proven its point beyond what is being shown. So, what's your take on the dedication bifurcation angioplasty, the left mains, the long left mains, and the way the DCB is coming up in a practice, going holistically for a single stent approach only, ending with a DCB to a side branch concept, or putting a stent only if you have a flow limiting dissection? Do you believe that the MACE rates will be much lower than two stents in left main bifurcation
Yeah,
PCI?
yes, I do believe that, but you have to see that what kind of lesion is it. There will be many lesions which will need two stents. You cannot say that everything will be one stent and DCB. You will have to choose your patient. How much is the osteoma circumflex involved? Is it a long lesion? Is it a calcific lesion? Because DCB may not work well in a calcium. So you have to see so many factors. Doing a left main bifurcation, you have to be safe also. Suppose the LCX closes, the whole stent will close. So you have to be very careful in selecting those patients. Yes, there will be a sizable number of patients in bifurcation, particularly LED diagonal, which now my preference is use one stent, use DCB for the side branch. Avoid a closure of the side branch, use DCB as much as you can. Avoid a second stent in LED diagonal or circ-OM, but not for all left mains where it will be selective patients where you may be taking some risks by not putting the second stent. So you should keep your mind open. Go as provisional stenting as your first strategy, but in patients with very complex lesions, you will be upfront with two stent strategy in many patients.
And as it has been for Sir for so long, do not complicate things. Things which are going absolutely fine, large proximal vessels where two stents have done reasonably well for a very long period of time, no needs no change. It is the problem of the smaller vessels and the branches like the diagonal sir is saying, where something needs to be changed, and where and this is exactly where the DCB comes in. Sir, with the current data allowing the use of DCB only in the small vessels, diffuse disease and ISR, now some data is also showing up in STEMIs also, 3-year data on STEMI and CTO PCI. Without extrapolating too much, what do you see that the bifurcation PCI, for that matter even CTO PCI, will we reach a space or a time in the timeline in future where stents will only be placed for a very subset kind of patients?
So this is a very important and pertinent question in the current day practice. It has not been answered. The guidelines have not put DCB as the number one therapy. They continue with stents. I think I need more data before I say. Yes, long diffuse disease, one should avoid stenting as far as possible. So if there's a distal disease in the LAD or a distal disease in circumflex, if you can get away with a DCB, I'll be happy. But saying that, ISR also, you have to be careful. If the data is still in favor of a DS in a DS, if this is a second stent, if there are multiple layers of stent, there is no question DCB is better. But still we need more data to finally firmly say, I want a stentless. I do want a stentless angioplasty, but do I have enough evidence to say that all my patients should now be DCB and not stents? Is not enough.
It's not enough, and it should not be enough. The data is what we are thriving for, and this is how we evolve our practice. It is not anecdotes and experience. This is obviously takes account, but strong prospective data is what we need to shift over from drastically from one therapy to another. Sir, for transcatheter aortic valve replacement, West has shifted pretty early into lifetime management after realizing that the patients are now outliving their first or even their first two valves. In that concept developing and picking up in India too, where the TAVI is still a single digit percentage for aortic valve replacement, how do you see the lifetime management for these kind of patients in India?
So if you talk of lifetime management, it is even more pertinent for two reasons. Our lifespan is going up. With each year that passes, Indian mean age is going up. Second, we have younger patients undergoing TAVI compared to the West. So lifetime management becomes an essential part. So whenever we put a patient on the table for TAVI, we have to be prepared that he's going to come back to me 10, 15 years from now. What am I going to do then? That has to be in your mind when you start the procedure. It is not that you want to finish off the procedure safely, which you have to, and that's not the end of the day. End of this day starts after you finish the procedure and then start thinking of his future.
This is even more important. What sir is trying to say, that the future you have to do it today, but you have to prepare for the future also. That when once these patients come next for the second intervention or maybe the third intervention, sir, do we see that the recent advance in the balloon expandable valves, the new generation devices coming in, we finally have a robust and reproducible solution for pure aortic regurgitation or the bicuspid valve anatomies?
So if you have an aortic regurgitation with a lot of calcification, well, these valves work. You can easily implant. But if it is a pure aortic regurgitation, not much calcium, it is going to be challenging. The newer valves have not yet come into the market. The GINA valve and other valves are working on it. And this will be the new therapy which will be looked into. The second thing about bicuspid valves, Indians, in my series almost 50% are bicuspid valves, are more challenging, more difficult to do. But if you've done a good job, the outcomes are same as tricuspid valves. So that is the good part of it, that if you do a good procedure, your end result and long-term prospects are similar to a tricuspid valve.
Sir has his own data and he's matching up his own data, but and he says that still we need to learn maybe the pathology also, maybe how the best valve forward for aortic regurgitation will be till the time it remains an Achilles heel as the ostium circumflexes. Sir, how do you like the CRISP conference and what's your experience has been like?
So this is the first time I came to CRISP, and I'm pleasantly surprised the interactions that are happening. So you have not thousands of people, but you have hundreds of people who are like-minded, and they are discussing the subject very nicely. So that at the end of the session, a clear message goes to the audience that exactly how to treat a patient. It's not theoretical meeting; it is based out of clinical experience, data, and telling you a message that this is the best way to treat a particular subject.
Thank you so much, sir. Thank you so much for the for coming and having a chat on the podcast. And this is Dr. Balbir Singh, sir, and we'll have a new guest on the next podcast. Thank you so much.